Hey, look, they say if you are patient enough, you accomplish what you are trying to seek. And yes, I wanted to get Dr. Christian Rolfo on my Healthcare Unfiltered podcast. It took forever, but here we are, and he's on the show. Welcome, Christian.
Thank you, Megan. Thank you for the invitation, Chadi. It's a really pleasure to be here.
And I'm really, really super excited to have you on the show because I've been meaning to really do a show exclusively on liquid biopsies. And I could not think, genuinely, I say that, not just your face, I could not think of a better person to be the right guest for the right topic. And that's why the wait is well worth the wait, because the way I've conducted Healthcare Unfiltered is it is better to wait long enough to get the right guest for the right topic. And here you are.
I appreciate it. Thank you. It's a pleasure.
So Christian, let's do a quick intro just for folks who don't know you, a little bit about you, where you are, where you may be after that. Just tell us a little bit about you.
Yeah, I'm Christian Rolfo. I'm a thoracic oncologist, but more than that, I define myself as a precision oncologist doctor. I currently professor of medicine at the Icahn School of Medicine in Mount Sinai, New York, and associate director for the Center of Thoracic Oncology for Clinical Research. And I'm moving now from here to a new position in Ohio State University, and I will be the division director for medical oncology and associate director for the Cancer Center for Early Clinical Trials. And my focus of interest is, like you say, liquid biopsy, early drug development. And in the lab, we are working specifically in some analytes of the liquid biopsy, including ctDNA, obviously, and exosomes or extracellular vesicles, that is the proper denomination, and CTCs. And I was doing, I have been doing that for the last 8 years of my career in the lab. So from Belgium, when I moved from Belgium to Maryland and here, so more than 8 years, 10 years on this lab's history.
Congratulations, first of all, on your move. We will see this episode may air before you move or after you move, but regardless, really, congratulations. It's a well-deserved move, and you're going to be moving to Columbus, one of my favorite cities, actually. I really love that city. It's small, it's nice, and so congratulations. Wonderful.
Thank you. And also the institution is really one of the major institutions in cancer care, and it's very exciting to move there.
Now, let me ask you this. Did you negotiate tickets to the Ohio State football games?
I think that was one of my questions because actually they welcome me into the Buckeye family, so I need to be there, and I know that they have very good discounts, so I hope to
There you go.
with my son.
Well, it's I mean, the stadium is amazing. I've never been, but my brother who is there at Ohio State keeps promising me tickets, but he has not delivered. So there's a lot of stuff about liquid biopsies out there, whether it is clinical care, research, everything. I wanna start by level setting a little bit and talk about the non-research stuff in terms of where it is being used. First of all, why do they call it liquid biopsy? It's a blood draw.
Yeah, it's a blood draw, but it was a fancy terminology that was put in together by two colleagues in Europe, Dr. Alice Panaviera and Klaus Pantel, that in one of the paper that they published, they put this term that I think is very nice to condensate all what we are doing with liquid biopsy with this blood draw using the liquid biopsy, because it's giving the idea that we are taking information, crucial information from the blood draw that is beyond the analytic or the common characteristic that we are taking from the blood. So that was the beginning, but nowadays we are putting together several other definitions. We need more definitions. That is the kind of terminology, but we need more definitions to make more harmonization on all the data that we have nowadays after several years that we are working in the field.
So when you do the blood draw, and we do the liquid biopsy, what information, just again, for folks who are listening who don't really do this every day and they're not really in the lab, What information are you actually getting when you say I'm doing a liquid biopsy?
Yeah, so the liquid biopsy is a big family. There are several analytes inside. The one that is practically used and is approved by FDA is the ctDNA. So we are taking from there a lot of information, specifically circulating DNA that we can capture, for example, mutations, fusions, and some important information in these genomic alterations that are there. And the beginning of this history was applied specifically in lung cancer. We have there a lot of opportunities to identify patients that they can benefit from druggable targets therapies. So we have the opportunity to see that, identify that, but also identify later on. We was working more in the identification of mechanism of resistance. And now we are in other area of the concept that is more the monitoring of the response, and that was translated to other area in advanced disease, to minimal residual disease in the terms of the perioperatory area. And then we are later on moving to early detection. That will be the next frontier. And so a lot of information from the ctDNA. Then we have other analytes that are, like I say, extracellular vesicles or exosomes. CTCs, for example, platelets, and others. So all the circulating biomarkers that we can collect are calling also liquid biopsy, or are part of this liquid biopsy family. In the practical issue, they are not, or the practical setting, they are not really used broadly, but what we can do with these other analytes is understanding process of the cancer, process of the biology. So there are several things that can be explained, for example, from exosomes or CTCs. And there is a bunch of research there that you can see is published frequently in the literature.
So this is a tumor DNA.
The ctDNA, yes, it's a tumor
DNA comes to the blood, and we're able to take it and look at the sequence of what's actually happening in the tumor DNA.
Yeah, there are different, obviously you say correctly, there are tumor DNA, there are also cell-free DNA that is not tumoral, but is also is in the circulation. So there you have different, we can say different granularities. Patients that are shedders or no shedders, that is another, the patients that you don't see the ctDNA, and that is in some cases is not related with the tumoral burden. Generally, ctDNA or the DNA is related with the quantity of tumor or the burden of tumor that is present in the patient. But in some patients, we don't have this ctDNA in circulation. We know nowadays that this is a prognostic factor, because patients that have ctDNA negative, they are doing better than the patients who have ctDNA positive from the very beginning. And then we are calculating also this DNA in different ways. So we have what we call BAF, or variant of allelic frequency, and that is very useful technology also that we have to monitor, for example, the decrease of this BAF or clearing of this BAF is related with outcomes in survival or even in response rate. So there are several things that we are working nowadays, and even new concepts like tumor fraction, for example, that are also incorporating in this. It's a very fascinating topic because we are adding more definitions, more use of the liquid biopsy, and more opportunities to develop new technology.
So my first question to you, Christian, though is, so I appreciate the fact that we're taking information about the tumor by doing the blood sample and sending that to the sequencer. But how accurate this is compared to tissue? Because we were always, as medical oncologists, we were always been trained, engraved in our brain, tissue is the issue, tissue is the issue. So we tend to always be nervous about things that are not coming as an actual biopsy from the organ.
Yeah, tissue is the issue, and sometimes it's an issue because we have patients that we don't have tissue enough to do the complete analysis of the next generation sequencing of big panel that we get all the information. So liquid biopsy I consider that it's complementary. We have actually several studies that in lung cancer, but also in other tumors, they were talking about the concordance between the ctDNA and the tissue biopsy, the tissue results that we get, and the concordance is very high. So I think this is not a problem. For the reason, we need to cut in some patients that we have less concordance or we have a liquid biopsy non-present, the non-sheathers or non-informative, new definitions like tumor fraction, like I said before, that is a kind of calculation, it's an algorithmic calculation that we can really understand if a liquid biopsy is negative or non-informative, can help us to understand better the concordance. But in several studies in lung cancer demonstrate that. It's true that there are some other tumors that the concordance could be less high. So and that is depending also on the biology of the tumor itself, the capacity or the location of the tumor, the capacity to erogate in the bloodstream, release in the bloodstream ctDNA, and that is a reality in some tumors, but is in lung cancer, in the area that most working is different. The concordance is very high.
So, but you really, when you started answering this, you mentioned sometimes you don't have enough tissue. I mean, that's really key. There are scenarios where you get tissue. I can also think of scenarios where the tissue is very difficult to get, like surgery or something like that.
Exactly.
Yeah, but today in 2024, what would you say the concordance between tissue and liquid? 80%, 90%? Like what's?
It's above the 80%. It's almost 90, 95% in the case of lung cancer. I repeat, lung cancer.
Okay.
It's very high concordance. Actually, we have different studies that the Nile, for example, just to show a trial that is historical trial, the Nile study that was published by the group of Natasha Leil, demonstrated a concordance that was very, very high, so almost 95% in some cases, with a high also sensitivity and specificity for the ctDNA. And actually, what was more important in this kind of studies is the complementary of the liquid and the tissue biopsy. I don't believe that liquid biopsy will replace completely tissue in all the aspects, because we have several information that is coming from tissue, but could be a complementary. And actually, in the first guideline that we did with ILCLC on the use of liquid biopsy, we discussed at that moment in 2018 the sequential approach. So we say if tissue is not enough, we will go for liquid biopsy. Later on in 2021, we did the second actualization, and in this update, we saw that there are other two approaches. One is like you mentioned, tissue is not possible to get there, so we call blood first, and actually this concept of blood first approach is applicable generally even if you're doing the two complementary approach, tissue and liquid biopsy, because the results you are receiving before, or even in patients that we don't have tissue enough, or we cannot get the tissue, like you say, because the localization of the tumor is really difficult to get a biopsy. And then we put, for me, the ideal approach that is the complementary approach, that is putting liquid and tissue biopsy from the very beginning. And why this is very important? Because you will have a complete picture from the beginning, but then you will have also a baseline characteristic to monitoring these patients later on. I saw several times that the people is doing sequential, and we have tissue, but then when we progress, we go for liquid biopsy and we say we didn't find nothing. But we don't know if that patient was a sheather or not from the very beginning. We don't know the characteristics of this liquid biopsy in that specific patient. So several considerations.
Yeah, and I actually appreciate the idea of the concurrent approach of doing tissue and liquid together. I guess, so hypothetically, let's say you're doing tissue and liquid, and then you find something in the liquid you did not find in the tissue. How would do you believe it? Do you not believe it? Does it depend? Like, what would you do? You do the tissue, you did the NGS on tissue, you got the results, then you did the liquid, and I don't know, something actionable. Let's forget the stuff that are not actionable. You found in the liquid. How do you determine if it's signal or noise?
If it's present in the liquid biopsy and it's there, is a target, is present there, I will believe 100% because when you have a tissue, you need to remember that it's a part of the history. It's only part of a portion of all the tumor. And the tumors are heterogeneous. So you can have areas of focus of in the same tumor or even in metastatic areas that are different with different clones that could be composing this tumor. And it's the same, just to explain to my patients, sometimes I use the comparison with a cake. I don't know if when you was a kid, maybe you eat this marmalade cake with chocolate and vanilla and different flavors. If I give you only a piece of the chocolate and I don't show you the cake, you will tell me that the 100% of the cake was chocolate. So that is the explanation of liquid biopsy. It's like putting this amalgama of flavors before we go to the oven and show that. So that is the opportunity to capture clonal evolution and heterogeneity. That is one of the advantages of the liquid biopsy.
I love that. I'm going to use that chocolate cake. You got me hungry. Okay, so that's a very good kind of like, setting stone into what we're talking about. I want to forget the research stuff just for a second. And I know I love research, you love research, and you're doing research a lot on this. But let's talk about the clinical current state of liquid biopsies, the standard of care. So are you performing liquid biopsies on every patient with metastatic disease from the get-go with thoracic oncology,
Sure.
with lung cancer?
Yes.
Is there any role to doing liquid biopsies, standard of care in early stage disease in lung cancer?
Yeah, we have now, in lung cancer, we have the approval now of anti-EGFR and anti-ALK treatments for patients that have adjuvant after resection. So in some cases, we are using in patients from the very beginning also the liquid biopsy when they have a stage that is possible to be getting information. I refer for stage 2 or stage 3 disease. And in that cases, we are doing also liquid biopsy. Is the standard of care? No, it's not still the standard of care, but could be nice to know because back to the fact that we was discussing that the presence of liquid biopsy is per se a prognostic factor. Would be nice to know that if it's present there in these cases. Actually, in the future we are talking about something opening a window for what we will see in the future. I will say that the incorporation of the liquid biopsy in the staging will be very instrumental to understand the biology of the tumor. So the TNM is not enough to calculate some patients, so we call now TNMD in some cases, and there are some papers speaking about that. So that will be a future, so we will take in consideration. But nowadays we are focused more in the determination of advanced disease generally from the point of view of the practical clinical application.
Yeah, I think that there's probably no one in the US or elsewhere that will ever dispute the prognostic value of finding the disease on the molecular level by blood. I mean, it's there, right? I mean, so it must be prognostic, and if you see it, means this patient is going to relapse sooner than somebody that you don't see it. What I think people struggle with, Christian, is what do you do with the information? Because, so you see let's take an early disease patient, and you're monitoring this patient, and then you find that somehow there's disease now on the molecular level. I think people don't know what to do with the information. So what's your sense? Like, where are you checking the liquid biopsies in metastatic disease and early stage disease? Let's do this. In early stage disease, you have a patient had surgery and
So starting from the metastatic disease or advanced disease, what I'm doing personally is in targeted therapies, I try to check the patients after they start the treatment, so having a baseline tissue and liquid biopsy. And from there, check in like is done in several studies after 6 or 8 weeks of treatment, between a window of 6 to 10 weeks, see how is the clearance of this mutation in the blood or fusion in the blood. Because there are several indicators that is correlated with a surrogate of the outcomes, no? Overall survival, progression-free survival, and specifically the response rate. That is what I'm doing in these patients. And also I use the liquid biopsy in some patients when we have outside that, in patients that are responding to the treatment, but sometimes you see some oligoprogression, and the idea to identify some biomarkers very early, you can change the treatment properly before the patient becomes symptomatic. So that is also, there are not guidelines about that, but it's what we are doing practically. In an early stage.
Let's do metastatic. Let's just quick question on metastatic before you go too early. Are there scenarios in metastatic disease where you clear the ctDNA completely?
Yes, of course. There are.
Can you stop treatment at that point? Can you say, I'm going to take a break?
That is not the idea, because we know specifically, if we are talking about targeted therapies, we know that this clearance is responding, or this complete the non-detectable information in the blood is due to the treatment that we are doing. And we know that for different studies also that there is the possibility to have flare in these patients when we are stopping the treatment. So I think there is not the indication. If we are moving to other scenarios, that could be immunotherapy. There are several also clinical trials ongoing, some preliminary data that demonstrate that this clearance also is immunotherapy correlated with the outcomes. And some studies, like for example, the B36 that is running by Dr. Ananostow from Hopkins, will demonstrate if this kind of approach is also useful for escalation and de-escalation of treatment in patients with immunotherapy. So I think this is clear. The use of this dynamics of BAF is a very important opportunity for monitoring patients and to change the treatment in time. In early stage or in minimal, here we have two different things. One is the early stage when the patient is diagnosed and they have a stage 2 or 3, and we go for surgery later on. So the first one is the diagnostic part, to see if there are some biomarkers, because we know that we have approved by FDA, as I say, 2 drugs for ALK and EGFR. But also we have several trials now that are looking for in targeted therapies, for neoadjuvant treatments in targeted therapies as well. So that could be, from the academic point of view, interesting to know. The second part is to monitoring when the patient is completely resected, the minimal residual disease. And there, I think we did incredible progress, but we are not still in the 100% that we need to be. We don't have still the robustness of confidence that we have in advanced disease in minimal residual disease. The technologies that we are using there are different. There are some companies that are doing, speaking about vendors, they are doing some tissue-informed approach, so following from tissue, creating that information or translating that information in liquid biopsy, or going directly, what we call tumor uninformed approach, that is going directly from the liquid biopsy to follow these patients and monitoring. Still there, patients need to be aware that we don't have 100% of confidence on that. So there are commercially available some technologies, but still images and symptoms and putting together other information is relevant. We cannot 100% trust in only the liquid biopsy approach. That is very important. As I say, we did impressive advancement in there, but I would like to see more data on robustness for application. And then we have the early part of the how I measure, and that is the scenario that we are very focused now, that how I measure the response in patients that have neoadjuvant disease, for example, how I can predict the response of these patients, how I can identify patients that are going to
No,
answer.
no, no. This is actually extremely helpful. I guess what, Christian, what in early stage disease with surgery alone, do we have data what how often surgery alone leads to MRD negative disease? Like you do surgery and there's nothing, you do the ctDNA and there's nothing?
We don't have big numbers. We have numbers of small trials that are giving this idea, the surgery, and also we have data, for example, coming from studies like the Empower 010, that you have the chemotherapy that is given in adjuvant is also reducing or doing the clearance of this ctDNA. Yeah. So it's not something that is obviously when you're doing surgery. You will have two different things there. In the beginning, if you're doing a surgery, in the first day of the surgery, you can have in circulation a lot of cDNA, so circulating DNA. It's free DNA, but not tumoral DNA in some cases because you will have a lot of inflammation and factors. But then you will have theoretically, when this tumor is out, you will have a decrease of this alteration that you were seeing before the tumor. And also you need to also see there some other data in terms of if the patient, when you need to do the time points to start to collect the time points for minimal residual disease, that is still also not a clear guidelines, but we know that at least you need to pass some days after the surgery to have a better understanding to start to measure.
I mean, well, part of me thinks that having the liquid biopsy and having the technology is a great opportunity to either escalate or de-escalate therapy. I mean, look, by definition, adjuvant therapy, we are over-treating people to cure some. I mean, that's by definition, because we give chemotherapy to everybody, for example. I'm not talking, of course, if you have the EGFR or the ALK is different. I'm talking, you still technically, even the ADORA trial, I believe a lot of patients received chemotherapy. So you still give chemotherapy to everybody because it adds that % of improvement in survival. And part of me is thinking, wouldn't it be great if I have a way to tell somebody that they don't need the chemotherapy. And that's, I would love to see data on this, or I would love to see you guys working on, instead of this randomness of deciding that everybody gets adjuvant therapy, maybe there's a way where we could tell a cohort of people, you don't need adjuvant, and another cohort, you definitely need adjuvant.
Yeah, that's obviously is one of the applications that we dream to have. There are some data, inclusive in patients, for example, if we put another scenario that is stage 3 population, that they are going under chemoradiation, and then consolidation of immunotherapy. Now we have approved recently also the opportunity to give, or we have the data to give EGFR TKIs for these patients with chemoradiation, so targeted therapies after chemoradiation in place of using immunotherapy. So there are some data that retrospective and a small trial prospective that show that in some patients you don't need to go for the consolidation in some cases when you have the liquid biopsy completely negative. Do we need more data? Yes, I think we need more data to really apply that abroad because the data are very small, some of the data are retrospective, but that is the kind of trials that we will need in large scale to understand which patients are really having a benefit or not to the addition of the consolidation in the case of the immunotherapy.
And I can see the value of the liquid biopsy in early stage disease. I think you articulated that very nicely in terms of the pluses and minuses. In metastatic disease, is there a reason to do serial liquid biopsies? I mean, essentially, you're following clinical progression. You're following CAT scans and all of this. And let's face it, the majority of patients do not go into complete response where you don't see anything radiographically. So most patients, they always have something that you can see on images. How does Christian Rolfo today use liquid biopsy in metastatic disease outside of clinical trials?
So as I say, I'm trying to get the baseline for all the patients, and then we are doing generally I'm doing after 6 to 8 weeks, another the window 6 to 10 weeks. You have the opportunity to do another liquid biopsy. Actually, some companies are now offering this kind of combo for free. And you have this idea how the patient is responding in this clearance that is a surrogate. And I'm not using again until I don't see a sign of progression or something, because I'm really interested to see the mechanism of resistance that is in charge of that. And in some patients, even with oligoprogression, we was able to have mutations that are responsible for progression and mechanism of resistance that are druggable. So it's really, really important to get when the patient is progressing, have a new testing for that. But it's very important to understand that, to have a baseline.
But why do I need 6 to 8 weeks? Like what am I going to do with the information?
So if you have a clearance of the ctDNA, you have the opportunity to demonstrate that these patients will have a better progression-free survival and overall survival according with the data that we have. And actually, the data that were presented in AACR for osimertinib in the trial, we have actually in some patients at 3 or 6 weeks, no big difference in the clearance or in the decrease of this ctDNA. So it's not standard of care. We don't have a guidelines where we need to do it, but we are focusing in the trials that we have from 6 to 8 weeks to do this analysis. But we are very lucky to live in a situation that we have the opportunity to be approved for this kind of technology is reimbursed. Otherwise, that is what we are talking today here. Maybe when I was living in Europe or when I was living in Latin America, it was completely different. And that is, I think we are privileged to have this opportunity.
Christian, there's a lot talked about the hematopoiesis of indeterminate significance, the CHIP, and that sometimes you see certain things in the blood that you really, at least for maybe the inexperienced eye, they may see something and it may appear to be a mutation that's coming from the tumor, but it may be completely because of age, smoking, whatever it is. How are you able to differentiate, I guess, to me, to signal from noise when it comes to some of these things that you detect in the blood?
Yeah, clonal hematopoiesis is could be a confounding factor in liquid biopsy, because normally with our age we are accumulating mutations in the non-tumoral cells, and there are some, I would say, classical or canonical mutations that are related with the clonal hematopoiesis. And these are very easy to find, but there are others. For example, now that we have KRAS as a biomarker, some of the variants of this KRAS, for example, 12D or 12B, could be clonal hematopoiesis. So it's important to distinguish that. There are no commercial platforms that are completely erasing this clonal hematopoiesis analysis. They are filtering, obviously, and they are not showing some of the canonical hematopoiesis, so don't confuse. But there are some other technologies that we can use, for example, using the analysis of using methylation, or using, for example, the analysis of the white blood cells as well, just to identify this. Is also there is another aspect of the clonal hematopoiesis, and that was coming out in the TAT in Paris recently in the Congress, that in lung cancer seems to be the clonal hematopoiesis having a prognostic factor that is negative prognostic factor, and that was from the group of Charles Swanton presented in the Congress. So there is a lot of research right now on this value as a biomarker of the clonal hematopoiesis, and we will hear more and more about that in the future.
All right, well, let's move. The last topic with liquid biopsy is the early detection. I think you alluded this in the beginning. These are healthy people who have no cancer that we know of, obviously. And basically, we're screening. And we're saying we're going to do a blood test and we're going to see if there's any signal that you may have cancer or not. I think it's probably one of the most controversial things that I believe when I talk about this and talk to people, and you could imagine why. So let's talk about today early detection. What is your sense about this? I believe you do some research on that as well, and you're very interested in it. But you can appreciate why there's so much controversy about it because. I mean, I'll give you an example, just a scenario. So I do the test, whatever you recommend the test for me, I do a test. And then I don't know what to do with the information. Do I do a scan every 3 months, every 4 months if it's positive? And let's say every 6 months, once a year, like there's so much uncertainty. So help clarify to us the current state of early detection and where this is heading research-wise, and where do you see it becoming?
So early detection is a fascinating area to research and is where we want to go because it's really the opportunity to cure patients and to see these patients completely eradicate from cancer. That's the idea, no? Unfortunately, we are not in the scenario that we want to go because the sensitivity is not so high. So here there are two aspects. One is the specificity, and in early detection, more than in other scenarios, the specificity need to be very high. So we are talking about more or above 90% to really trust what we are seeing. And then we can go for the sensitivity. Now the sensitivity in the methods that we have, that there are some of them that are commercially available, that they have a commercialization approval. For example, multi-cancer detection test, sensitivity is not the same in different tumors. And even in the same tumors, different scenarios, for example, adenocarcinoma or squamous is completely different. In breast cancer, hormone receptor positive or hormone receptor negative are different in sensitivity. So I think there we need to be very careful and very responsible with the application of that. So there is not an FDA approved still application for or commercially available technology that we can use. We need more information about that. We need more trials. Some of the trials were showing still false positive, and this is a very concerning area because, like you say, if you have a positive and non-images, what you need to do, you are putting a patient maybe in a very stressful situation with not really positive or completely positive biomarker. So it's really a stressing situation. So we will need more and more research. There are other options now. We are moving to other directions, and maybe it's not the multi-cancer. Maybe it's a single tumor. Maybe it's not only ctDNA, and I mean methylation. Maybe it's more multi-omics approach. There are companies working in metabolomics. There are companies working in proteomics. So could be still an area that we can improve a lot, but the impact of this research in liquid biopsy in early stage will be really, really significant when we get a technology that is not only able to be as a companion diagnostic of a screening program, but also standing by themselves as a method that you can apply worldwide. So it's really interesting. In some areas, for example, in colorectal cancer, there are some very nice data coming and were published actually in the New England Journal of Medicine, some data on the addition of colonoscopy, and they were a little bit further, that is more the precancerous lesions. So the future of liquid biopsy could be the cancer interception. So the cancer interception using liquid biopsy because they are UDOC ablation.
So, but you could, again, at its core though, and I look like I'm frozen. At its core, liquid biopsies are screening techniques. In this situation, early detection, they're really screening. You're taking healthy people and you're saying, I'm going to do a blood test, and that blood test is going to tell me if you are at risk of developing these cancers. So this is really a screening. And in general, in all screening technologies or recommendations that we have, there's set criteria of high-risk population. I mean, in your area, in thoracic oncology, you do CT scans in specific populations of current smokers, all of these things. We all know that. Mammograms, PSA, and obviously there are a lot of controversies on screening, but the one thing that is not controversial about screening is that you screen a certain population that you perceive at higher risk of developing the disease. In liquid biopsies for early detection, that piece appears to be missing. It seems like just take everybody. And I think that's my beef with it.
No, no, absolutely. And there are some trials, for example, using fragmentomics that they were including high-risk population. Not only in lung cancer, but for example, in hepatocellular carcinoma, fragmentomics show a very nice data also in patients of high-risk population. So I think this is a very important point that focus on this population. But in the case, obviously, we would like to have something that is capturing the 20% of the patients that are never a smoker. So, and they have potentially non-risk per se. Could be a second-hand smoker, could be radon, could be other things. But having some technology that is helping to that, I see the potential, obviously, of the multi-cancer detection test, because if you have a patient, put the scenario of a female with 65 years old that is a heavy smoker. This person is not only unable to have an lung cancer for the tobacco, it's also for a screening of head and neck, for a screening of uterus, for breast cancer. So putting all this screening together and simplifying with a liquid biopsy will be an ideal approach. How sensitive is that? Nowadays is not the 100%. So we need still to work on that, and that will be better in the next future. We will have better technologies for sure.
But I mean, if you put your researcher hat on, just the biggest question that you guys need to answer as you resolve this issue is what type of tests need to occur if you have a positive test, right? And how often? Obviously, we both agree that the test will be based on the type of cancer that we think is going to be. I don't know why I keep freezing. So let's say you do, I don't know, you do a early cancer multi-cancer early detection test, and it shows you that you are at risk of having lung cancer. I think it's easy. You just keep doing CAT scans. What's not really clear is how often you do them.
Yeah, no, obviously. I think there are several questions that we need to answer still for the application. And as I said before, be very responsible on the application of that, because that the fact that this is commercially available doesn't mean that we need to use it everyone and indiscriminate.
I think the one commercially available test I'm aware of is the Galleri test, and disclosure, I don't get paid by Galleri, or nor do I. Neither of us do that, but it is available. It's direct to consumer. It's not FDA approved. It's an LDT, I believe. Have you had patients reach out to you and say, hey, should I get that test? What do you suggest? I mean,
there are some patients that they have that, or they use also the minimal residual test that I'm not really using still. But I was surprised that I was in a conference long time ago, and I asked some medical for general oncologists, who of you are using that, and I saw several hands raising in the room, and I was concerned about the education that we are giving to the doctors and the scientific community and the clinical community. So I think we need to also educate the population about that, and be, obviously, everybody wants to have a very nice method to select that, and now we have, I see several commercials or reels that are talking about MRIs and general MRI for people, or CT scans. So I think we want something that is immediate, but we need to be very responsible that still we are not there, and try to to be careful with the expectations. What I was really interesting, and I was really happy to see this year that when we have the screening last year in November, the awareness month of lung cancer, I was very happy to see that there are advertisement about to do the screening programs. We don't need to forget that the screening programs outside the liquid biopsy are really important, and make that universal is really crucial.
Christian, is there anything I should have asked you about liquid biopsies that I completely overlooked and forgot? You've been very generous with your time, but I want to make sure I cover everything. But is there anything I forgot?
No, I think we was covering almost all the part. We didn't discuss about research, but that could
What
be
are you
part.
What are you working on?
So we are working in different things. We did a model recently of an extracellular vesicles of a predictor biomarker for immunoresponse, trying to figure out how to predict patients that are good responders or not immunotherapy in advanced disease. And what we did actually was the membrane of the extracellular vesicles testing the PD-L1 and looked at the dynamics over the time. So applying this concept of dynamics over the time and incorporating also the radiomics. So a multi-omics approach to generate data on responders. That is one of the things. And then we was working actually in early detection. We are working in a multi-omics approach with metabolomics, and the sensitivity there is very, very high, and specificity is very high. This is in collaboration with some researchers and vendors in Canada. And recently we published something also in tumor fraction, that is this concept to understand the liquid biopsy positive or non-informative, negative or non-informative. So giving some light on the shedders and non-shedders. So it's very fascinating, all the research and the community of liquid biopsy. And I profit your space to invite everyone for our society, the International Society of Liquid Biopsy, and our annual meeting that will be this year on 23 to 25 November before Thanksgiving in Denver, Colorado. And I hope that you can visit us, and more information on our website, ilslb.com.
I'm more than happy to come to the meeting and cover it as a reporter.
That will be great. That will be great. You're more than welcome.
Well, Christian, congratulations on your move. Congratulations on all of the amazing work you're doing. I think your impact on liquid biopsy research and what you've done over the years is solidified forever. So I appreciate you giving me the time and spending some time with Healthcare Unfiltered.
No, thank you. Thank you for your thoughtful questions and really give me the space to discuss a topic that I'm really fascinated with.
And I can't let you go without the mandatory picture that we're going to put on Twitter, as you know. I mean, but unfortunately, I'm not very well. I don't know how to do much pictures, so I just take it from my phone. And yeah, I mean, we are taping during Copa America, so I believe we definitely do not want Brazil to win or do not want Argentina to win. Remind me.
Argentina need to win. We have there a very extraordinary group, and beyond Messi, and win Messi obviously, but it's it's part of the passion of our country, and Brazil as well. They are very passionate about that. That is the beauty of this sport.
Absolutely. All right, my friend. Congratulations and good luck, and I hope to see you in Columbus very soon.
Thank you. Thank you very much.